How do we make a borderline unresectable gallbladder carcinoma resectable? By neoadjuvant chemotherapy and portal vein embolization prior to the resection. Chemotherapy is experimental in gallbladder carcinoma. We give modified FOLFIRINOX. Liver hypertrophy occurs after portal vein embolization. In non-cirrhotics, this is much faster than cirrhotics. So in non-cirrhotics, the fastest regeneration is 12 to 21 centimeter cube per day at 2 weeks, 11 centimeter cube per day at 4 weeks, and 6 centimeter cube per day at 32 weeks after the portal vein embolization. In cirrhotics and in diabetics, it's a little slower. That's 9 centimeter cube per day at 2 weeks. Doing a TACE followed by portal vein embolization gives you a much higher liver residual volume, that is FLR, that's future liver remnant, because necrosis increases the rate of liver regeneration and there is no hepatic artery buffer response. So the 5-year disease-free survival is much higher when you combine the two. Who needs pre-op biliary drainage? If they need an extended right hepatectomy, when the hilum is patent, we do endoscopic drainage. If not, we do a PTBD. In hilar blocks, never put metal stents because it's hard to get out. It's a nightmare to remove it. Use only plastic. Adjuvant chemotherapy. So in the BILCAP study, which actually did not reach statistical significance, they used capecitabine, which is oral 5-FU. Endoscopic palliation is done for jaundice, for pain, and for gastric outlet obstruction. But most gallbladder carcinomas are unresectable with a survival of only 2 to 4 months. PTBD versus endoscopic biliary drainage. PTBD is shown to be superior, higher successful drainage, and decreased risk of cholangitis. But the endoscopic, there's a decreased risk for bleeding compared to PTBD. The 30-day mortality is the same in both. SEMS versus plastic in hilar malignant stricture was studied by Hang et al., and this was in the European Journal for Gastroenterology. Meta-analysis of 6 studies showed that SEMS had a higher successful drainage, a decreased early complication, and longer patency. But it was associated with a higher cost. Usha Datta et al. Gave data on gallbladder carcinoma in India in 2019. And they said that the age in India was 51 years median compared to 71 years in the West. It's 10 times more in North and Northeast India compared to the South, and women to men ratio is 4 to 1. The reasons why gallbladder carcinoma was more prevalent in North and Northeast India was the polluted Ganga with heavy metals and pesticides. Fecal coliform count is high in Ganga, and there are a lot of typhoid carriers also, and typhoid carriers are known to be carriers of a risk factor for gallbladder carcinoma. Use of mustard oil, which is an irritant and mixed with margarine, it is a carcinogen. The risk factors for gallbladder carcinoma are many. First of all, cholelithiasis. If the gallbladder stone is more than 1 centimeter, 65 to 90% of gallbladder carcinomas have stones in them, and there's a 7-fold increased risk of gallbladder carcinoma in patients with cholelithiasis. But only 1 to 2% of patients with gallbladder stones end up having a gallbladder carcinoma. Next is porcelain gallbladder. Then adenomatous polyps in the gallbladder, especially if it's more than 1 centimeter, if it's sessile, and it's associated with a stone, and if it's hypoechoic. APBDU, which is 10% of gallbladder carcinoma cases have this. If we find it, we have to do a prophylactic cholecystectomy. Adenomyomatosis of the gallbladder. There's invagination of the mucosa called Rokitansky-Aschoff sinuses. PSC, 20% patients develop gallbladder carcinoma. 40 to 60% of gallbladder mass in patients with PSC are gallbladder carcinoma. Then IBD is also a risk factor for gallbladder carcinoma. Chronic carrier state of S. typhi and parotyphi. First degree relatives have an increased risk of 13.9-fold. Obesity increases the risk twofold. And then there is aflatoxin. The pathology is an adenocarcinoma, papillary, tubular, and nodular varieties. Pathogenesis, the fundus is the most dependent area, and there is poor contractility here, and therefore it's prone to chronic infection because of a poor outflow, inflammation, increased COX2, increased INOS, and TP53 mutation is seen in 35 to 90%. MDM2 mutations are seen in 80%. HER2 and new overexpression is seen in 10 to 15% cases. Clinical features. 50% are found incidentally on a cholecystectomy. And if there are symptoms, the most common one will be pain. It's severe right upper quadrant pain. Next, there is gastric outlet obstruction, which is seen in 10%, and then they can have jaundice. Clinically, we can find abdominal mass, which is hard, it moves with respiration, it's felt in 30 to 50%. They can also present with acute cholecystitis. Imaging. Ultrasound sensitivity is 85%, specificity is 80%. The sensitivity is true positives divided by true positive plus false negative. CECT abdomen and thorax are used for staging. The findings that you can get are a subhepatic mass which obscures the gallbladder, focal or diffuse mural thickening more than 1 centimeter, intraluminal mass more than 2 centimeters arising from the GB wall, no acoustic shadowing on the ultrasound, PET-CT for distant metastasis. Staging, the TNM staging. Let's deal with N and M first. NX, it cannot be assessed. N0, no evidence of nodes. N1, 1 to 3 regional nodes. N2 is more than 3 regional nodes. M0, no metastasis. M1, metastasis. TX can't be assessed. T0, no evidence of primary. T1, TIS is carcinoma in situ. T1 is divided into A and B. So T1A would be invasion of the lamina propria. 1B is invasion of the muscularis propria. T2, connective tissue is involved. T2A would be peritoneal side. T2B would be hepatic side. T3, visceral peritoneum. And T4 would be vessels. That's the portal vein or the hepatic vein, or even extrahepatic organ involvement. Stage 0, then you have stage 1, which is only T1. T2A would be, stage 2A is T2A, stage 2B is T2B, stage 3A is T3, stage 3B is any T that's T1 to T3 with an N1, T4A is T4 with any N with no metastasis. So you have stage 4 is straight away T4. And what we say T4 was? Vessel involvement, portal, vein, or hepatic artery, or extrahepatic organs. That makes it straight away T4, stage 4A. What about 4B? 4B is any metastasis. Once there is a metastasis, it's stage 4B, whatever be the T, whatever be the N. So 4A and 4B are very easy. 4A is just T4 with any N or M. 4B is any T with metastasis. So you have 3B, that is T1 to 3 with a node. Nodes have to be present in 3B. But 3A is T3 without nodes. Okay. Treatment. Surgery is the only curative option, but only 20 to 40% are actually resectable. The types of surgery we can do are: one, simple cholecystectomy, that is for TIS and T1A. What do we say T1A was? 1A is this, only involving the lamina propria and not going beyond that to the muscularis. So right up to the lamina propria, you can just do a simple cholecystectomy with 95% survival rate at the end of 5 years. Radical cholecystectomy is you remove the gallbladder along with 2 centimeters of gallbladder bed along with regional nodes. You have to remove the head of the pancreas as well, plus celiac nodes. This is for 1B and for 2. And this also has a good survival of 60 to 90% at 5 years. However, extended radical cholecystectomy includes para-aortic nodes. You have to do a pancreatic or duodenectomy as well, plus or minus bile duct removal. This is for T3 and above. Neoadjuvant chemotherapy is not shown to be beneficial. Adjuvant chemotherapy we give with capecitabine. The trend is positive, but there is no statistical benefit. What they give is gemcitabine plus cisplatin or gemcitabine plus oxaliplatin. Palliative chemotherapy, 5-FU or gem plus pembrolizumab if the patient is MSI, H or D, MMR positive.